Now, everybody is actually into gym and fitness. We all know nowadays it's quite been a regular practice for everyone to enhance his or her fitness by going to the gym. Plus, we have a lot of teens and young adults who are actively actually participating in sports, especially the baseball at the university in college level. We'll be coming on to the topic which is actually more related towards the sports injuries, that is the bicep tendon injuries. As you know, briefly coming to the anatomy of the bicep tendon, it has two heads. There is a long head and there's a short head. The long head starts from the supraglenoid tubercle of the scapula. As it descends down in through the rotator interval, it goes all along the bicipital groove. That is a groove which is present between the greater tuberosity and the lesser tuberosity. And on the top of it is actually the covering a transverse humeral ligament. As it descends down from this onward, it attaches onto the this is called as bicipital tuberosity of the radius. Then there is a short head. The short head starts along with the conjoined tendon, which is also a tendon common for the brachialis, coracobrachialis, and the lesser head of the bicep. It starts from the tip of the coracoid, as you can see it over here, as descends down, comes along with the long head, and eventually attaches on the bicipital tuberosity. It is supplied with the musculocutaneous nerve, which is part of the lateral branch of the lateral division of the brachial plexus, and the root value is C5, C6. As it descends down on the bicipital tuberosity, there is a proximal part. On the proximally, it's a long head, and then when you come distally, it's actually the short head. The most important mechanism of the bicep is actually to supinate the forearm. This mechanism is actually the most important mechanism, that is the supination of the forearm. It, to some extent, it also causes the flexion of the elbow as well, although the main flexors are some other muscles. As I told you, this is the head of the humerus with the greater tuberosity. This may actually, the anatomy is important to understand when we are understanding the bicipital tendinitis. As you know, tendon may get inflamed, leading to inflammation of the tendon or tendinitis, sometimes also called as tenodesis, which is actually abrasion of the tendon, leading to some form of a tendinitis as well. What is important here is that it has two heads, and most commonly involved head is actually the long head. Why? Because of this, it's actually coming from supraglenoid tubercle, entering into the area of the rotator interval. There is a bicipital groove through which it has to pass. There is a transverse humeral ligament on the top. It actually has not enough space to move around. That is the result. It's actually in a very tight space. So some slight inflammation of this tendon eventually actually may be quite symptomatic and quite painful for the patient. So that is important to understand, that as it goes through the bicipital groove between the greater and lesser tuberosity, this is area which has highest chance of getting inflamed mostly. And it attaches it on the lesser radial tubercle. If you can appreciate moreover in this anatomy, this is actually a view from the back. There is a supraglenoid tubercle, long head goes all the way like this, while coracoid process from the tip, it is actually going like this. Now if you appreciate it over here, there may be a slight change in the anatomy as well. Not always the tendon of the long head actually starts from the supraglenoid tubercle over here. If this is happening, there is a large rotator interval, but over here the rotator interval is quite short, and the head of the humerus is actually lying quite near to it. So this is very important when you're understanding the causes of the tendinitis. As I told you, there is one cause is actually the transverse humeral ligament, which is forming the roof of the bicipital groove. Other is the coracoid itself. If you see it over here, the tendon, if we're going to be passing, the long head going to be passing just inferior to the coracoid. It can get trapped over here. It can get rubbed against the osteophytes or the hooked acromion as well, or even the coracoid process of the ossified of the coracoid process. So this is actually what happens due to the increased friction, due to increased movement. There is increased abrasion effect, and this leads to synovitis and tendinitis of the bicipital tendon, or eventually which can also lead to avulsion or proximal bicipital tendon avulsion. And usually most common involving is the long head. Now coming to the how to test the person with the bicipital tendinitis. What's important is that patient usually comes whenever the patient comes. Usually there is always associated complaint of wedge anterior shoulder pain. Bicipital tendinitis may be associated with rotator cuff arthropathy or rotator cuff tear as well. There may be signs symptoms of subacromial impingement as well. If you can appreciate the anatomy again, as it crosses the rotator and towel, if the subacromial is impinging from the top due to hook acromion, or there is an ossified acromion, this can also actually produce the symptoms which are mimic the subacromial impingement or bicipital tendinitis. So the first and foremost is always the speed test. What is the speed test? The way to do it is that you ask the patient to comfortably sit on the couch. You can also cause the patient to stand up and do this test depending upon what is your preference. Patient can sit and do this test as well as can stand up and do this test. But what you need to understand is you need to stabilize the shoulder with one hand, that is usually with the left hand. Ask the patient to forward flex your shoulder, that is at almost 90 degree, with the elbow extended and forearm supinated. This is important. Forearm should be supinated. And you ask the patient to raise your arm from this 90 degree angle up above the head, and you resist it with your other hand. Now this is important. If it's your left shoulder, your right hand would be on the shoulder and you will be resisting the patient's arm by your left hand. Similarly, if it's the right shoulder, your left hand would be on the shoulder and you will be resisting the patient's arm with your right hand. As you resist, if it produces pain, especially if it produces anterior shoulder pain, most likely this is the impingement of the bicipital tendon leading due to the bicipital tendinitis or tenodesis. Now, other option is Yergason test. As I told you that anatomically the main function of bicep brachii is actually the supination of the forearm. This is a test in which the patient can be comfortably seated and the forearm can be pronated with elbow maybe flexed to 90 degree, or it can be flexed to at least 70 to 80 degrees. Now at this level, you put your hand on the top of the forearm and you ask the patient to supinate the forearm against resistance. The arm is in pronation and examiner is putting his hand like this, and you ask the patient to supinate the arm against resistance. As the main function of the bicep brachii is actually the supination, this produces the pain, especially over the anterior shoulder region. This means the Yergason test is actually positive. Now, if it is a bicipital tendinitis, now other options is usually if you go for an X-ray, most likely it will reveal no abnormality. There may be you may be able to find out what is exactly causing the bicipital tendinitis. Maybe an ossified across the coracoid, or there may be subacromial ossifieds, or there may be subacromial arthritis which may be impinging it on. Usually the most common method is actually to go for an MRI. MRI will reveal inflammation, fluid collection, and increase in signal intensity, especially on the T2 weighted MRI. Now, if we know that it's bicipital tendinitis, then the mode of treatment initially is always conservative. Conservative means we can start with rest, as increased movement will increase the pain, so patient can be given analgesics along with the decrease in activity, especially overhead movements of the shoulder. Then local heat physiotherapy is one treatment option. This is all conservative. Then we may have to go for deep transverse friction rub. This is actually a technique. If the problem is with the transverse humeral ligament, this rubbing can actually decrease the amount of pain via gate mechanism theory. Then is a corticosteroid injection. Although it's a tendinitis, but what you need to remember is that we can give a corticosteroid injection near the tendon, not into the tendon. If we are by mistake, if we give it, it's ideally should be done ultrasound guided, because if it's done blindly, this can be problematic, because the doctor may inject actually the tendon into the may inject steroid injection into the tendon, which actually causes the tendinopathy or rupture of the tendon actually. So we have to remember that we may have to actually infuse this injection around the tendon, which will actually decrease the local inflammation and pain as well, later on giving strengthening and physical therapy to the shoulder. Now, if conservative measures does not help, or the patient actually complains of recurrent episodes of bicipital tendinitis, and the most likely cause is actually the inflammation of the tendon itself, then we can go for certain procedures, which may be most commonly, initially it was done openly, but nowadays arthroscopic tenotomy and lasso procedure is actually quite common. Arthroscopically, we go in, and if you see it over here, the long head was coming from this area, from the supraglenoid tubercle. It was coming like all the way down through the bicipital groove and then descending down. This area has all been cut, because this is where actually the maximum friction or rub actually takes place, and then the suture is anchored as actually into the bicipital groove. This is actually a bicipital tenotomy. Other procedure includes the lasso technique. What is the lasso? Is actually in North America, they usually use a rope with a neck at its end for especially the cattle herds are actually tied down by use of a lasso technique. They throw out a rope with a neck at the end, and when it gets caught in the neck of the cattle, as the cattle tries to move on, it actually tightens. This is basically the lasso technique. So what they do is, this is what is done arthroscopically. All the tendon is actually removed, and a suture anchor is placed in such a way that you tighten a suture in form of with the neck in its end, and as the patient actually the passive movement of the tendon actually takes place in the rehab process, this neck further tightens up and actually creates a lot of grip. This is a lasso technique for the treatment of bicipital tendinitis. Now, if the other option includes actually the tenodesis, if there is lot of inflammation, abrasion and fraying of the tendon, we can cut this area and apply a suture anchor either in the bicipital tuberosity, or the other option is actually applying it in such a way that this tendon is hole is drilled through the bone and tendons get rerouted into another area. This is actually to prevent lot of abrasion, but this is also one way of doing it. But actually the main function of the tendon is actually the supination, so too much rerouting may actually impair the supination. So best option is actually applying a suture anchor right into the bicipital tuberosity, which will hold it in place. Now, other is arthroscopic decompression. Arthroscopic decompression is actually to rule out what is exactly causing the tendon issue. For example, we can go for only the edges can be trimmed, all the synovitis can be removed, and we can go for arthroscopic debridement as well. There may be a chromion may be impinging on it. We can shave it off, or we can shave off the extra fibrotic tissue as well. All this can also help out before this is one way of actually helping it out with the tendinitis. But if we feel that despite the debridements, despite the shaving of the fibrinous tissue, still the patient will have the recurrence of a problem, then we can go for tenodesis technique, as like in, for example, lasso, or applying a suture anchor and applying cutting the bicep tendon and fixing it in the bicipital groove so that it actually relieves itself of compression. Then comes the rupture. If a tendinitis is recurrent, or if it's not resolved, treated properly, or if the patient does not take care much, for example, patient is an athlete who has, for example, is a baseball pitcher. The function and the main role of that person is actually to pitch the ball. Then when increased throwing, this may actually initially produce instability, which will eventually may lead to proximal tendon rupture. Usually this may be associated with slap lesions, as we will be discussing the slap lesions later on, or it may be actually isolated rupture. Now, the bicep tendon can rupture in the proximal area. As I told you, the anatomy is such that there are two heads, which is actually starting from the supraglottic tubercle, long head from the coracoid process. Or it can rupture at from the distal end, where it is actually attaching at the radial bicipital tuberosity. So it's important to know that whenever you are actually dealing with the bicep tendon injury or bicep tendon rupture, the first and foremost would be actually there would be a history of acute trauma or acute episode of throwing activity. For example, if the person is a baseball pitcher, he would complain that he had acute trauma, and after that he has actually lost velocity and as well as grip over the his pitching strength, as well as there's actually loss of control as well. And this is actually maybe due to there is instability along with associated with the rupture as well. Now, as I told you, anatomically it can rupture proximally or at the distal level. Most commonly, usually the long head ruptures, and it's mostly in the rotator interval. Now, if it has ruptured, there may be associated with a Popeye deformity. For example, there was a cartoon which is called Popeye, in which the one eats spinach, actually his biceps swell. When you ask the patient to pose like that Popeye, there is actually swelling the bicep because there's a rupture from the proximal area, and whole of the muscle actually collected over here in the lower. This is called as Popeye deformity, which it usually happens when there is a proximal rupture of this. If there is a distal rupture, for example, if the tendon is ruptured from the bicipital tuberosity of the radius, then what actually happens is that there is the hook deformity, hook test is negative. If we ask the patient to actually supinate the forearm against resistance, because at that time the bicep is contracting, you can actually hook your index finger below the distal part of the bicep. But if it is ruptured, first of all, there will be no supination against the resistance because patient will be unable to do it. And if passively the forearm is supinated, you cannot be able to hook your finger below the tendon because the tendon would be probably ruptured. As I told you, there is a proximal rupture or it could be a distal rupture. Now, proximal rupture usually can be treated arthroscopically or as well by use of suture anchors through simple posterior arthroscopic approaches. A distal rupture, there are different techniques to treat the distal rupture, like single incision techniques and dual incision techniques. They both have their own pros and cons. With dual incision, you have less injury to posterior trochleus nerve, radial nerve, but with single incision, there is increased chances of injury to lateral brachial cutaneous nerve or even the radial or posterior trochleus nerve as well. Depending upon which technique suits the surgeon, usually and single incision technique is not utilized, but also it has its own pros and cons. Continuing with the rupture, this is what I was talking about, the Popeye deformity. What has actually happened is that you can appreciate the tendon, the lower part is over there, but the long head has ruptured, and as a result the whole muscle mass is actually gathered in the lower portion. This is classical when the proximal avulsion of the bicipital tendon takes place. and results in a Popeye deformity. Now coming to, if there is a proximal rupture, we can go for, depending upon, most likely the common cause is actually the hook acromion. The hook acromion is impinging on it, and during the movement, initially it produces tendinitis, and eventually it may lead to the rupture of the long head of the bicep. So you not only have to repair the long head of the bicep and suture anchor it somewhere else, also you have to take care of the problem which is actually causing this issue, that is the hooked acromion, and which you have to go for anterior acromioplasty, which can nowadays easily be done using a arthroscopy of the shoulder technique. Other option is, once the hooked acromion, the problem which was actually causing this rupture, has been removed, then we can go for bicep tenodesis as already explained. It could be by a lasso technique, or it could be a simple suture anchor technique, and the bicep can be resutured using an anchor into the bicipital groove, or it could maybe associated with the rotator cuff and pathology as well. So we may have to arthroscopically repair the rotator cuff along with the repair of the bicep tenodesis. There's a rare entity called as the hourglass bicep. Now, hourglass bicep is actually, usually it's a rare form, and usually what happens is that if you see that as the long head starts from the supraglenoid tubercle and it descends down through the bicipital tuberosity, between bicipital groove between the greater and the lesser tuberosity, there is actually a constriction over the top of the bicep. This actually makes it into an hourglass. There's a constriction in between, swelling in the top and the bottom. This leads to an hourglass kind of an appearance on MRI. Usually the most common cause is actually the calcification of this transverse humeral ligament, or it could be the pathological due to the bone formation over the top of the tendon, and the tendon may be going through a tunnel which is actually formed. This is a very rare condition, but if it happens to be secondary to some form of a problem with the transverse humeral ligament, then we need to address it, because otherwise it will produce the recurrent tendinitis of the bicep, as the tendon would rub either on the proximal or on the distal edge of the hourglass appearance. Usually the clinical features of this include pain and block to the terminal elevation. Patient may have a problem with elevating the arm above the head, especially the buckling of the tendon on elevation as well. We may be able to visualize it or even palpate it. Especially the supination and flexion of the forearm is quite painful, along with instability of the bicep. Why instability of the bicep? Because bicep, as I will be discussing later on, that actually bicep is anchored over the superior labrum, and if the labrum is actually, it provides, as you know, anatomically, the glenoid is a small area and the head is quite large. To accommodate for a large head over the small glenoid bone, there's a labrum which actually attaches to the glenoid and provides it an extra depth, so that it actually kind of seals the mechanism as well, and helps in the movement over the shoulder as well, and stabilizes the shoulder. But if this superiorly, when the labrum is actually attached to the bicep tendon as well, and once there's a rupture, or there's tendinitis, or there's a avulsion or instability of the tendon, this actually results in either the instability of the labrum as well, and especially during the throwing activities or during the overhead movement of activities, the patient usually complains that there is instability, and he feels as if the shoulder is actually giving way, or it's about to dislocate or subluxate. That is the kind of a feeling usually what happens due to when there is instability of the bicep tendon. As I told you, the imaging is far and foremost is usually the not AP may be stable, but in this type of a view, you can appreciate there is a subluxation that is almost, it's intact, but it appears to be moving out, although it's not completely dislocated. Dislocation is when it is completely out, either anterior or posterior dislocation, which is anterior is more common in the case of the shoulder joint. Then comes the slap lesions. Now, this bicipital tendinitis associated with rotator cuff, subacromial impingement, then hourglass bicep slap lesions are all actually problem which is occurring at the almost same area. This subacromial impingement also occurs just above below the subacromion and just above the bicipital tendon. Bicipital tendon is lying right there in the rotator cuff. Along with attached to it is a superior labrum. So it's actually, if one problem starts, it actually propagates into another lesion, and they usually associated with almost similar kind of symptoms. This instability, there is problems especially in the overhead movement or throwing movement, there is anterior shoulder pain, and there may be when you get an MRI, you get actually sometimes there is an incidental slap lesion as well. Patient may be complaining of some other problems and may be getting treatment as well, but when you get an MRI, end result is you get a slap lesion. So as I told you, anatomically, this is the bicep tendon, which is actually originating from the superior labrum. This is the labrum which is actually like attached all around the glenoid, and from the superior part of the labrum it anchors the bicipital tendon as well. And this is important because it not only provides stability to the labrum, but this anchorage also helps to actually stabilize the shoulder as well. This is the humeral head with the greater and lesser tuberosity. This is the bicep tendon which is passing through the bicipital groove. This is the labrum, and superior part of the labrum is maybe attached to the bicep, which may tear off, forming to the slap tear. What is slap? S stands for superior labrum, and anterior to posterior tear of the bicep labrum is actually the slap form. Mnemonic is slap, but it's actually superior labral anterior to posterior tear of the labrum. Now there is a classification, although it has been modified a lot as well. Initially it was 4 subtypes. In type 1 was there was the fraying of the superior labrum, although this bicipital anchor is actually intact. In type 2 there was complete tear with intact anchor. You can appreciate the bicep is intact, but the tear is actually complete, involving the superior labrum. Type 3 involved a bucket handle tear with actually the fraying of the anchor of the bicipital tendon. Now in this bucket handle tear, actually there is a large tear along with the anchor of the bicep is also disturbed. In type 4 there is actually the rupture of the bicep anchor along with the bucket handle tear of the superior labrum. Now the important point is, as the stage increases, the intensity and the problem actually also increases, because dealing with this would be far easy as compared to the bucket handle tear. With the loss of the bicep anchor would mean that you need to correct the bicep as well as the slap lesion as well. This actually classification has been modified, and now there's actually 5, 6, 7, 8, 9 and even 10th type as well. Then these actually types, the further modification was actually done when there was type 2 may be associated with certain other lesion as well. There was superior labral anterior posterior lesion as well, along with the tear primarily more posterior or most primarily more anterior lesions as well. And there were other lesions which may be involving, initially the tear started at the superior labrum, but then it spread all along into a round shape kind of a lesion. Depending upon, primarily there are only 4 classification, but it has been modified into almost now 10 types. And this is how you can appreciate it on MRI, that this is all the glenoid tubercle is like this. There's the labrum around it along with the capsule and bicep attached on the superior pole of the labrum. There is the coracoid process. This is the spine of scapula, and labrum is attached is the yellow part. You can appreciate it over here with the capsule outside the labrum. This is what happens when there is a tear, that the labrum gets detached, which may be associated with such as just fraying of it, which is type 1, or there may be actually a whole tear without even disturbances of the biceps tendon anchor, or there may be bucket handle tear with Some amount of disturbances are fraying of this anchor as well. This type 4 would mean there will be bucket handle tear along with the avulsion of the suture anchor as well. Now coming to the clinical features. The clinical features, the foremost is usually the painful click, especially during the throwing activity, because during the terminal phase there is actually slight instability. This is the glenoid, and actually the humerus comes out slightly anteriorly, and this actually produces a classical click which is usually visible either anterior superiorly or during the terminal phase of the throwing. Other option is the loss of power. As the bicep cannot stabilize the shoulder joints, usually the athletes complain, especially the baseball pitcher, they complain of whenever they throw the ball, there's actually a click and there is actually reduced velocity, and his or her coach is actually constantly telling him that you have to pitch the ball with a greater velocity, but despite his maximum effort, he or she is actually not able to do it. This loss of power is actually due to instability which is being produced with the shoulder joint and inability to throw. Eventually, initial phase may be the loss of power, and eventually if things get grossly unstable, or the labral tear actually expands throughout, or is a kind of a tear which involves all the parts of the labrum, the patient may not be able to throw the ball properly, and eventually throwing will lead to dislocation of the shoulder joint. There is an O'Brien test which is actually done to clinically evaluate for the slap lesions. One way of doing it is that patient is asked to raise the arms up till 90 degree with the shoulder at 90 degree, elbow in extension, and the forearm is actually pronated and maximum internally rotated. When you put the thumb downward, this actually maximally internally rotates the arm. With this position, you put your hand on the top of it and push it downwards and ask the patient to resist it. If pushing downward against resistance actually produces pain, this means that there is a positive slap lesion, and this would usually produce a pain over the anterior shoulder joint. Other option is that you can ask the patient to have the same kind of situation, that the shoulder is at 90 degree with elbow in extension, but forearm is in supination with the thumb outside, means that ask the patient to maximum externally rotate it. Once the forearm is maximum in external rotation as well as extension and the flexion at 90 degree at the shoulder joint, you push it downwards and ask the patient to resist. If this resistance actually decreases the pain as compared to previous test, or completely the pain disappears, this is means that the positive O'Brien test is actually positive for slap lesions. Now imaging. Usually first and foremost in orthopedics is always the X-rays. But in slap lesions, we may have to go for an MRI or even the diagnostic arthroscopy. This is how it appears. If you can appreciate here, the tendon is attached on the superior labrum. This is the bicep tendon which is anchored over it, and this is producing a bucket handle type tear of the superior labrum, and you can appreciate the glenoid underneath it. This is how it looks like on MRI. If you see it over here, as I told you, this is a superior labral lesion, and from anterior to posterior lesion, and you can appreciate it over here that this is actually fraying, mainly showing of the superior labrum with most likely the intact bicep tendon. Now coming to the treatment. Treatment initially is to start with arthroscopic repair. This is usually acute tear may be repaired by arthroscopically by use of sutures. That is, this is where it is that you apply the sutures to this and you anchor it back to the bicipital tendon. This is one way of doing it. But if it's a chronically maltreated lesion, or if it's lesion which is incidental finding and patient may have instability and patient may have associated rotator cuff injury as well, then you need to treat it with suture anchors. That is, instead of repairing it, you need to suture these anchors into the glenoid bone and then tie the superior labrum to these anchors. This is actually a more concrete method, because in the chronic injury, usually repair results in a recurrence or re-rupture of the slap lesion. As you can appreciate it over here, this is an arthroscopic technique. Arthroscope is through coming through the posterior portal, and the instruments are actually coming through another portal as well. And you can appreciate it, the suture anchors, threaded anchors can be placed into the glenoid bone, and this anchors can be used to tie it like all inside technique, and this will eventually result in the repair like this. Usually two, depending upon the size of the lesion, maybe three suture anchors may be required to repair the slap lesions. This is also showing a schematic diagram of the repair of the slap lesions. You can appreciate it over here. The three anchors been utilized and all large tear has been repaired by use of the suture anchors. What happens is that actually these anchors are providing a base which is being anchored into the glenoid bone, and the sutures are being actually applied which are involving the bicep along with the superior labrum and being reattached. And the bicep tendon is being re-anchored to the superior labrum, which is actually getting re-anchored to the glenoid bone like this. There's another term is called as slap lesion tenodesis. What happens is, as you know, that if there is such a situation in which there is a slap lesion along with the avulsion of the bicipital ligament, one way is to repair it if it is possible, or we can do is we can cut this area, go for bicipital tenodesis, so that it actually does not causes recurrence of the slap lesion, and we can repair this slap lesion separately. This is also possible, and this is arthroscopically as well as open surgery, both can be done, but this is one way of treating. Usually nowadays suture anchors are more than enough to treat the slap lesions, and usually the humeral tendon anchor is actually placed at the same place like this, and you can screw it to attach the bicep back to the humerus at a different level, and you can repair the slap lesions separately. Bicep tenotomy is one of the option for the tendinitis as well, or even if it is associated with slap lesion, you can go for acute repair and go for tenotomy. What would that do? As I told you, anatomically, as the supraglenoid tubercle, the long head starts, it comes all the way back through the rotator rumble into the bicipital groove, and here there is a transverse humeral ligament which is actually on the top of the tendon. If by arthroscopically that is actually cut to relieve the tendon of the pressure and abrasions which is actually causing it. This not only relieves the most important cause of the tendinitis, and usually the if the pressure effects are also removed, and it also leads to tenotomy of the bicep tendon as well, and usually it relieves some form of the pain which is actually associated with the overhead movements of the shoulder joint. Now coming to another entity called as the frozen shoulder. Although it's very commonly people have heard about it, frozen shoulder, and usually it's very common especially in the females of 40 to 60 years of age, and especially those who are diabetics. What is a frozen shoulder? It is actually fibrinous adhesions of the capsule of the shoulder joint. As I told you, the concept of shoulder joint is like a T on the ball kind of a concept. As you have seen, a golf ball is quite a large size, and the T on which it is resting is of a very small size. What happens is the golf ball is like a head of the humerus, and the T is like a glenoid. Glenoid is small, and there's a large head on the top of it, and this actually produces inherent instability as well. So then there are stabilizers in form of the static stabilizers, which are ligament, and then there are ligaments and capsule which act as static stabilizer, and then dynamic stabilizer in form of muscles. So what happens is that glenoid, there's a labrum which attaches to the glenoid, which actually gives extra depth to the glenoid. Then outside that glenoid, there is actually a labrum, there's associated capsule, which is also attached to the glenoid as well as the labrum. Now this capsule actually provides actually a kind of a tight seal to the shoulder movement, that despite the excessive inherent instability and lot of movement over the shoulder joint, still there is least amount of dislocation and subluxation of the head of the humerus. This capsule becomes thickened For any reason, if there is a fibrosis of this capsule and there's a formation of adhesions, actually other name for the frozen shoulder is adhesive capsulitis. That is why it is called as there is inflammation, fibrosis, and eventually leads to decrease kind of a fibrinous strands which actually lock the shoulder joint. Now, if this becomes thickened and fibrosed, this would actually impede the movement, although it will provide increased stability, but it will impede the movement which would occur with the shoulder joint. And that is what exactly happens with the frozen shoulder. With the frozen shoulder, there is a loss of passive as well as active range of motion. Usually, when active range of motion is compromised, this may be due to the loss of any muscle tear or tendon tear. But if passive and active both are lost, this means that actually the capsule which is actually getting adhesive, or it is actually getting fibrinous, which is causing a frozen shoulder. Classically, there are three stages of the frozen shoulder. One is usually called as the freezing stage, when actually the fibrosis starts and there is synovitis and adhesive capsulitis along with the freezing of the shoulder joint. That is the decrease in the range of motion, which is quite painful as well. This is usually the first stage. This is this stage of the freezing stage. This almost starts, this may stay around for 6 weeks and as long as for 4 to 5 months. Patient may be in this kind of situation for as high as 4 to 5 months. Once this stops, there is a start of the second stage, which is actually in this stage, and this is called as the frozen stage. Now, when the frozen stage means that actually the capsule has actually completely become fibrosed, and there's complete loss of active and passive range of motion, or the active and passive range of motion are actually completely decreased. Then comes a thawing stage. Now, thawing stage is actually the third stage, which starts right over here. That is, thawing stage is like as you have taken the meat out of the refrigerator, it gradually thaws out and becomes more supple and it can be cooked. This is exactly what happens with the capsule of the shoulder joint as well. That it, instead of becoming more stiff and frozen, it gradually thaws out, becomes more flexible and less fibrinous, and eventually some degree of movement actually starts. So this is what exactly it. The range of motion is at highest when before the start of the disease, but when this freezing and painful stage starts, this is gradually the pain is increasing and the range of motion is decreasing. And eventually what happens is this is the stage where the least amount of the movement is possible. But at this stage, you can appreciate the pain is quite in the higher states area. But when this is the stage of the frozen area, when actually the maximum pain is there and least amount of range of motion is there. But as the thawing starts over right on this situation, range of motion gradually increases back to normal and pain gradually decreases back to 0. This is usually called as natural history of the frozen shoulder. But this can be interrupted by different techniques, because when we are treating the natural shoulder, we have to understand at what stage the patient is. If, for example, a patient is the freezing stage, you have to counsel it properly, because that freezing stage eventually will take at least 4 to 6 weeks to eventually become the frozen stage. With frozen stage, there's pain will eventually increase despite the treatment of analgesics. But you have to make them and counsel them that eventually this will thaw out and pain would decrease with a range of motion will increase, and you need to just go for the physiotherapy at that time. So the treatment is, more importantly, it's association as well. As I told you, it's more common in the female, involving 40 to 60 years of age, associated with certain diseases. Especially, for example, there is associated fibrinous disease, or in which there is tendency of the body to be increased fibrosis, for example, Ruptures disease. Or there may be associated with diabetes. Especially common is the diabetes and cardiovascular diseases, which are usually associated with hyperlipidemia or hyperthyroidism or hemiplegia as well. Usually stroke patients have a tendency, because there is not increased movement taking place, and usually this results in increased fibrosis of the capsule, leading to frozen shoulder kind of a situation. What would the clinical features? Clinical features, as I told you, depending upon the stage. If it is a freezing and painful stage, there's actually aching in the arm and the shoulder. There's initially there is a loss of active along with the all sorts of passive movement as well. And when the examiner tries to externally rotate, internal rotate, abduct, reduct the shoulder, there is actually also a decreased range of motion of the passive movement as well. Pain will increase initially severity during the freezing stage as well, and once the thawing starts, the pain decreases, the tenderness decreases, and slightly there is a regain of the movement of the shoulder joint as well. Now, the most importantly, it's actually a clinical diagnosis, which scratch test is quite of helpful as well. This is how it actually, the scratch test is done. As you ask the patient as if he or she is actually scratching his or her back, and the hand, if this is the shoulder which is actually involved, if this is testing the left shoulder, the most important the loss will be of the external rotation of the arm, and this is usually very common. Therefore the patient will not be overhead or would not be able to move the shoulder in the forward flexion above the head, then externally rotated to bring the hand down to touch the hand of his or her back. This is actually not possible with the patient if he's having a frozen shoulder. And though if you can appreciate it over here, the right shoulder is having a problem, she's unable to bring the hand back because of the loss of external rotation. How to make a diagnosis? As I told you, mainly the diagnosis is clinical, but you need to confirm your diagnosis with the help of a radiology, that you can get an AP and lateral view of the shoulder joint, or even MRI as well. And MRI and the shoulder joint would actually usually be normal, just that will be MRI may show increased thickening of the capsule, and especially the increased synovial hypertrophy, which may be pointing on towards the increased fibrinous adhesions of the capsule of the shoulder joint. Then comes the differential. There are a lot of differentials which may be positives as well, and may mimic the findings of frozen shoulder, may mimic these conditions actually. And you need to be very sure the patient now has no associated fever or a pain like which may be associated with, especially in diabetic patients. They may have an underlying infection which is actually causing this side of synovial hypertrophy and eventually leading to adhesions. Or it could be some to post-traumatic stiffness. Patient may have a history of a fall, which may have resulted in some form of soft tissue injury, and now actually patient has not moved his or her shoulder very much after that fall, and this has resulted in stiffness of the shoulder. It's not actually the frozen shoulder. Or it could be diffuse stiffness, which may be associated with some other underlying fibrinous disease. Or it could be reflex sympathetic dystrophy. The pain over the shoulder may be diffuse and would be problematic, and patient will not be moving his or her shoulder joint due to the pain. So when you're trying to passively move them, it also actually pains and hurts. So that's why the patient resists the movement of the shoulder joint, even the passively. So sometimes the reflex sympathetic dystrophy mimics the symptoms of the frozen shoulder, but you need to be absolutely sure that this may be associated with other diseases such as Raynaud's as well. Or is it purely frozen shoulder, or is it one of the reflex sympathetic dystrophy? Treatment of the frozen shoulder initially is always conservative, which could be in form of first you have to give analgesics depending on the stage. If it's painful stage in which it's freezing, or it's frozen stage, this is actually quite painful, you have to give analgesics. And along with that is you have to start the physiotherapy. Physiotherapy involves exercises at home which involve circumduction, abduction, adduction of the shoulder, as well as forward flexion and backward extension of the shoulder joint, and pushing against the wall and upwards as well. Now all these movements actually produce, the main movements are abduction, adduction, internal rotation and external rotation over the joint, and circumduction actually is a culmination of all the movements. These all movements needs to be done so that there is but maximum actually stress should be placed on the external rotation, because that is mostly affected more as compared to other movements of the shoulder joint. If the conservative treatment is not helping it out, for example, we can start with NSAIDs and analgesics. Then we may have the steroid injection. Intra-articular steroid injection has a role, because that actually causes increased lysis of the fibrinous adhesions. There may be associated with Other options could be operative, include which such as manipulation under anesthesia. This was quite a fancy option, but nowadays it's less practice because it has actually gone out of date kind of a surgery. But what you used to be done was that patient was given anesthesia, and once the anesthesia was given, patient was actually not feeling the pain, and manipulation of the shoulder joint was done so that to break all those adhesions of the capsule. But actually post-operatively it was associated with a lot of pain because this was actually the thickened capsule, and when you break those adhesions by manually and post-operatively, there was a lot of inflammation, and actually there was a lot of recurrence as well. So it was not actually kind of helping it out completely. But now with the new techniques available, manipulation under anesthesia actually gone out of fashion. Other is arthroscopy. That is why now we are moving towards is that is arthroscopic release or arthroscopic adenolysis. That is how it is nowadays is done. That arthroscopy is used to lyse those especially the fibrinous adhesions which have actually been formed in the shoulder joint. And arthroscopic capsular release can also be done as well. Capsular release is actually where there is a lot of thickened capsule that can be shaved off or debrided, but we have to make it sure that some part of the capsule should be kept there because it is actually providing a static stabilizer of the shoulder joint as well. In this, we have mainly covered the injuries which are mainly related to the shoulder joint. As the first, we started off with the bicipital tendinitis, which is quite common in athletes, which especially in the baseball pitches, which may be associated with anterior shoulder pain, rotator cuff injury, or even the problems such as increased pain, especially elevation of the shoulder above the head. Most important way to diagnose is by use of speed test. Then there is conservative measures along with the arthroscopic release of it. Nowadays, almost such a disease like bicipital tendinitis, tenodesis, even the slap lesions, more and more they are actually used to treated by arthroscopic repair and suture anchor techniques. We have actually shifted from open surgery towards the arthroscopic surgery of it. Then what's important is that bicep tendon actually is a very important integral part of the glenoid labrum, and it actually not only helps to stabilize the shoulder joint but also actually helps to stabilize the labrum as well. Therefore, once the slap lesion develops along with the bicep tendon avulsion or anchor avulsion, then it has to be repaired accordingly, and usually conservative measures are not good enough. You have to go for arthroscopic repair by use of sutures anchor. Thank you very much. Keep watching sqadia.com.